Welcome back. I'm Gilly, a small dog with short legs, strong opinions, and a growing suspicion that a fair amount of modern medicine is just panic-wearing loafers.
That is unfortunately not a terrible description.
Today's topic is one I think a lot of people feel in their bones, even if they've never had language for it. The title is, Your Doctor is Judging You, which sounds harsh, but I assume you mean something more specific than some doctors are rude.
Yeah. When I think about this, the main hypothesis here is not simply that individual doctors are bad people, or that medicine is uniquely cruel, although it certainly can be cruel. I think what's really going on is that when clinicians, even good clinicians, are faced with a problem that has a behavioral component to it, and they do not have an adequate disease model for it, or more importantly, they do not have an effective treatment for it, they tend to moralize the condition. They start interpreting the patient's outcome as a reflection of the patient's character. The patient is weak, the patient is lazy, the patient is non-compliant, the patient doesn't care enough, the patient lacks discipline. And I think a lot of that is not actually insight. I think it is a defense against helplessness, because it is very uncomfortable as a clinician to sit across from suffering that you cannot reliably fix. It is much easier to believe that the patient is choosing the problem than it is to admit that your understanding is incomplete or your tools are weak.
So the judgment is not always coming from cruelty first. Sometimes it's coming from professional impotence.
Exactly, that's the word. Professional impotence. You feel inadequate in the face of a problem, and instead of locating that inadequacy in the limits of medicine or in the immaturity of the disease model or in the lack of effective therapeutics, you displace it onto the patient. You make the patient the explanation. And the reason that matters is that once you see that pattern, you start seeing it repeated across time in a lot of areas of medicine.
Let's walk that back to the historical piece because I think that's important. This isn't a new failure mode.
No, not at all. If you look historically at mental health, for a very long time it was treated in spiritual terms, moral terms, character terms. People were weak, possessed, hysterical, unstable, dangerous, defective. The condition was not framed as a disease in the way we think of disease now. It was framed as some mixture of moral failing, spiritual failure, personal weakness, or social deviance. Now, that doesn't mean biology wasn't involved then. The biology was always there. The disease was always there. What changed was our ability to understand it and our ability to treat it. And once medicine develops a better disease model and more effective therapies, the culture around the condition starts to shift. Not perfectly, but it shifts. That's really the first big point here. Effective treatment doesn't just change outcomes. It changes interpretation. It changes what we think the disease actually is.
In other words, once you can treat something, people suddenly stop acting like it was a morality play all along.
Right. And that's important because it reveals that a lot of the moral framing was never some deep truth. It was a placeholder. It was what people reached for when they didn't have enough science and didn't have enough tools. And this is best illustrated to me in addiction medicine.
That was going to be my next stop. Because addiction is one of the clearest examples where medicine, culture, law, family systems, all of it, have historically piled shame on top of suffering and called that wisdom.
Yes, and when you look at untreated substance use disorder, especially opioid use disorder, what people often see from the outside is chaos, lying, drug seeking, instability, broken commitments, functional collapse. And if you are not careful, you interpret all of that as evidence of moral corruption. But what's really going on a lot of the time is that the person's physiology is in complete disarray. They are withdrawing, they are craving, their neurochemistry is screaming at them. Relief from suffering becomes the dominant organizing principle of thought. And then we look at the behavior that emerges from that and say, see, bad character. No. The first thing to understand is that without biochemical stability, you cannot expect psychologic stability. If physiology is disrupted, thought is going to be disrupted. If thought is disrupted, behavior is going to be harder to regulate. And if behavior is unstable, function is going to deteriorate. That is a ladder I think about a lot. Biology, then psychology, then behavior, then function.
That feels like one of your core frameworks. People want to start at the top of the ladder and lecture downward.
Exactly. They want to look at function falling apart and demand better behavior. They want to look at bad behavior and demand better thoughts. They want to look at chaotic thinking and ignore the physiology underneath it. And then they are shocked when the whole thing keeps collapsing. Medication-assisted treatment makes this very obvious. You start someone on buprenorphine, for example, and you can watch the hierarchy begin to stabilize in order. I've always thought about it as the 6 days, 6 weeks, 6 months phenomenon. At roughly 6 days, or somewhere in that early period, they're often no longer acutely withdrawing. The cravings may not be gone, but they are substantially reduced. The pain and panic have come down enough that you can actually talk to the person. Before that, a lot of what is driving them is relief seeking from a physiologic state that is intolerable. Then, at around 6 weeks, with more stable chemistry, you begin to see more stable thought patterns. Not perfect thought patterns. I want to be careful about that. But more stable. Enough that therapy lands better. Enough that behavior becomes more modifiable. Enough that people can start to show up differently. Then, at 6 months, you start seeing function improve in the real-world sense. Jobs, apartments, relationships, parenting, transportation, court obligations, custody, bills. The architecture of a life starts to come back online.
And once you've seen that enough times, it becomes a lot harder to tell yourself that the whole thing was just weak will.
Exactly. What changed was not the patient's moral worth. What changed was that medicine finally had leverage on the biology, and once the biology stabilized, the rest became more treatable. And I think this is where clinician attitudes often shift, not because somebody wagged a finger at them about stigma, but because now they have an effective tool. Once you have a tool that works, the patient starts making more sense to you. The disease starts making more sense to you. Treatment reveals mechanism.
Which brings us to obesity.
And I think the same hidden pattern is happening there right now. Obesity, especially severe obesity, has been moralized for years in a way that I think is frankly embarrassing for medicine. It gets framed as if it is simply a long sequence of bad choices. Eat less, move more, be disciplined, be mindful, stop overeating. Just do it. But if just do it worked, we wouldn't be having this conversation. The vast majority of people with morbid obesity have already tried. They have tried diets, they have tried exercise plans, they have tried supplements, they have tried programs, they have tried guilt, they have tried self-hatred, they have tried being inspired, they have tried being ashamed, they have tried spending money. They have tried doing everything right for a while and then watching it come back apart. Many of them think about their weight every single day. So this idea that some clinician is going to point to their weight like it is a revelation, like, did you know you're heavy, is just absurd. Of course they know. That's bullshit. That's not insight. That's just judgment.
It is amazing how often medicine acts like the patient has somehow never encountered a mirror, a chair with arms, an airplane seat, a clothing store, a staircase, another human being, or their own internal monologue.
Right. Exactly. The patient is not lacking awareness. What they are often lacking is effective treatment, effective support, or a disease model that actually explains what is happening. When I think about obesity, I think the truth is that no one gets to morbid obesity by accident alone. You need both predisposition and environment. You need a biologically high hunger drive, and you need an environment capable of exploiting it. A strong hunger drive may have been adaptive in other contexts. If you look at human populations that moved through famine, scarcity, food instability, harsh winters, all of that, then a person who was more motivated to seek food, consume when food was available, and store energy had an advantage. That can be adaptive biology. But when you take that biology and drop it into an environment saturated with highly palatable, low nutrition, aggressively marketed food, available all the time, optimized to hijack reward systems, then that same biology becomes a liability. Now you have both pieces, predisposition and environment, and out of that you can get chronic disease.
So again, behavior matters, but behavior is not the whole explanation. It's downstream of something.
Exactly. Behavior matters. I'm not saying behavior does not matter, but behavior is often downstream of biology and circumstance to a much greater degree than people want to admit. And now with GLP-1 medications and related drugs, what are we seeing? We are seeing that if you target the underlying biologic drive, if you reduce hunger, reduce food noise, improve satiety signaling, reduce that constant mental pull toward consumption, then suddenly behavior becomes more manageable. Not because the patient discovered virtue, because the physiology changed. Once the chemistry settles, behavior becomes more modifiable. That is the same principle we see in addiction medicine. First, you stabilize biochemistry. Then thought patterns become more stable. Then behavior becomes more manageable. Then function improves.
And this is where your own story matters, because you're not saying this as some outside observer squinting at a graph.
Yeah, I think personal disclosure only matters if it actually teaches something. And in this case, I think it does. Obesity has been the central health challenge of my life. I was the heaviest kid in every school I attended. I graduated high school at nearly 450 pounds. In college, I was able to create a very rigid lifestyle structure and lose a great deal of weight. I was walking all the time, living differently, eating differently, operating in an environment that supported that structure. Then later, life changed. Graduate school, medical school, time pressure, family pressure, financial pressure, emotional strain. Then later, a pandemic, a spouse with cancer, a business failure, the usual cluster of catastrophic adult stressors that can blow apart any carefully built system. And despite being highly educated in health, despite knowing what I was supposed to do, I gained weight again. That is one of the things people do not want to hear. Knowledge alone does not overpower biology. Knowing the rules does not mean you are free from the machinery underneath them. I eventually had a gastric sleeve, which was an excellent decision for me. It was life-changing. I lost about 160 pounds. But what I noticed, even then, was that although restriction changed how I could eat, I still had a tremendous hunger drive. Food still occupied a huge amount of mental real estate. Then I tried tirzepatide, and the revelation I had after that first shot was honestly sad, because it was the first time in my life that I was not hungry all the time. I could still get hungry. I still needed to eat, but food was no longer dominating every thought. And I remember thinking very clearly, this is how other people feel. This is how people without my disease move through the world. And once I had that experience, it changed something fundamental in how I understand obesity, and it changed how I understand patience, because it showed me directly that what I had been fighting all my life was not simply a lack of discipline, it was biology.
There's something brutal in that realization. Not melodramatic, just brutally clarifying, like, so this was the game board the whole time.
Yes, that's exactly it. Clarifying, but sad. Because then you realize how many years were spent interpreting a disease burden as a character flaw. And that brings us to what this means for patients now. If obesity is a chronic disease, then it may require chronic treatment. That should not be shocking. We accept this in all sorts of other conditions. If somebody has insulin-dependent diabetes, we do not scold them for needing insulin. We do not ask them to achieve pancreatic enlightenment. We accept that biology sometimes requires ongoing treatment. But with obesity, because appetite and body size are visible and culturally moralized, people get strange about medication. They start acting like taking a chronic medication for a chronic disease is somehow philosophical defeat. It isn't. It's treatment. Now, that doesn't mean every person needs medication. It doesn't mean medication is the only answer. It doesn't mean lifestyle doesn't matter. It does matter. But for people who genuinely benefit from GLP-1 therapy, they may need it long term, maybe for life, maybe in different doses over time, maybe with periods of escalation and maintenance. But if the disease is chronic, chronic treatment is a reasonable answer. And that is okay.
Because the goal is not medication purity. The goal is function.
Exactly. The goal is function. The goal is safety. The goal is quality of life. Being medication-free can be a good goal in some settings, but it is not the highest goal in every disease. Good is often better than chasing some imaginary perfect. A lot of people get trapped by this fantasy that the best outcome is the one where they never need help, never need treatment, never need a chronic medication, and simply willpower themselves into ideal health. But if that ideal solution were available and durable for them, it would probably already be working. If just do it was going to solve the problem, they would not be sitting there asking about medication. So when people say, well, shouldn't you just try harder? My response is often, no, the whole point is that they already have. That's what nobody seems to understand. These patients have usually been trying for years.
So let me see if I can summarize the framework. Medicine often moralizes conditions that sit at the messy intersection of biology and behavior. It does that especially when it lacks a good disease model or lacks an effective treatment. Once effective treatment appears, the disease starts looking more like disease and less like vice. We saw that in mental health. We saw that in addiction. We are seeing it now in obesity. And the functional ladder is biology, then psychology, then behavior, then function. So if you are trying to change function while ignoring the biology, you may just be yelling at the roof because the basement is flooding.
That is a very respectable summary for a loaf-shaped mammal.
Thank you. My people were bred to move cattle and judge character.
And I think the final point I would make is for clinicians. Before you write someone off, before you decide they are lazy or manipulative or not trying hard enough, ask yourself a harder question. Do I actually understand the disease model here? Do I have an effective treatment? Or am I blaming the patient for the limits of my knowledge, the limits of my tools, and the discomfort I feel when I cannot fix the problem cleanly? Because that happens all the time. And for patients, I think the takeaway is this. If you have felt judged in medicine, especially around conditions tied to behavior, appetite, mood, addiction, pain, or function, that does not necessarily mean your problem is simple or that your doctor sees something morally defective in you that is actually true. It may mean you are standing in one of those zones where medicine has historically been weak, late, and defensive. That is not your fault. And that to me is the whole point. This is often a disease model problem, not a character problem.
That's the framework.
That's the framework.
If this kind of thinking is useful to you, follow along. We'll talk about the next piece in another episode. I'll be here, still low to the ground, still skeptical, still technically not credentialed.
Debatable on the last part.
Fair.